Good evening, everyone. We welcome you all to OrthoTV in association with Pulse Pharmaceuticals. To introduce today's topic and speaker, I hand over to Dr. Harsh Chaturvedi.
Thank you so much, Dr. Bijlani, and a very good evening, ladies and gentlemen. This is Dr. Harsh Chaturvedi welcoming you on behalf of Pulse Pharmaceuticals, a Hyderabad-based company, to a very exciting tête-à-tête between Dr. Kiran Acharya of Manipal Academy of Higher Education and Dr. Ram Prabhu, Director of Mukund Hospital, Mumbai, on FRAX Score, revisiting to assess clinical benefit or a waste of time. Later in the program, ladies and gentlemen, we will be joined by Dr. Kiran Prabhu, who will lead us through the question answer session and will help us in arriving at suitable and desirable conclusions. Before we initiate this program, I take this opportunity to tell you in brief about my organization, Pulse Pharmaceuticals. As I mentioned, it is a Hyderabad-based company known for innovation in nanopharmaceuticals. We have our flagship brand as Deksel, which is a vitamin D supplement developed as a nanotechnology product and probably one of the very first functionalized vitamin D formulation. We have our research and manufacturing facilities spread across the country and are manned by around 1,500 personnel in various functions. Our interest, ladies and gentlemen, in musculoskeletal health is communicated through brands, as I mentioned, one which is Deksel, which is a flagship brand, Bakbone for taking care of pain, Bakbone addressing osteoporosis and certain risk factors like homocysteine, and I'm sure somewhere during this tête-à-tête that will also come up, and Professor Kiran Acharya and Dr. Ram Prabhu would be addressing that. Extracal, which is a very soluble form of calcium, and knee flex, which is a very recent introduction to our portfolio. Ladies and gentlemen, today's program is envisaged to bring out the relevance of FRAX tool in Indian context. Though probably there is already an Indian version which is available, yet somehow this instrument probably remains a very underutilized one in the clinical settings. To make us appreciate its usefulness and also its limitations, we have a very august panel. The names I have mentioned earlier, but I will take a few moments to introduce them. First and foremost, we have with us Dr. Kiran Acharya, who is a professor and head of arthroscopy and sports injury unit and orthopedics at KMC Manipal. Dr. Acharya is a graduate of KMC Manipal and also has done his MS from the same university. He has a diploma in trauma and mass casualty situations, FAO from Duke University, and has received bioskills training from Mangalore, Germany, Barcelona, and Thailand. He has been involved in research, and to his credit, 5 of his students have received PhDs. He has given numerous talks, I believe, almost, I'm told that 107 conference presentations Dr. Kiran Acharya has made over the years. He has published in index journals. He has more than 65 publications in them. He has given 212 guest lectures and has written 4 chapters in various textbooks. His special interests, ladies and gentlemen, include arthroscopy, sports injuries, joint preservation, osteoporosis, and biomechanics. He is an avid collector, I'm told, of instruments, medical instruments, and memorabilia. Writing instruments, he loves to collect. And I must say, ladies and gentlemen, he has a very strange kind of hobby of collecting matchbox labels. He puts it, well, many, I'm struggling to pronounce it because this is the first time I've come up that word. But I do remember Dr. Acharya, as a child, I used to collect those. And I share that hobby. And also, ladies and gentlemen, Dr. Acharya is an avid reader. Recently, I got to know he loves music and he collects some very rare books. With these words, I welcome Dr. Kiran Acharya to this Tête program with Dr. Ram Prabhu. Ladies and gentlemen, I'm sure everybody knows Dr. Ram Prabhu, a very senior orthopedic surgeon. He is currently the director of Mukund Hospital at Mumbai and also a consultant with Hiranandani Hospital. For almost more than 30 years, Dr. Ram Prabhu has been associated with BN Desai Hospital at Mumbai in various capacities. And he has started his journey in medicine with graduation and post-graduation from renowned St. G.S. Medical College and KEM Hospital. And subsequently, he went on to do advanced courses in spine trauma from Germany and France. Later, he did fellowships also from various places, including US, with trauma, spine, and arthroscopy and joints. Dr. Ram Prabhu has delivered numerous lectures, orations, and has participated in symposia nationally and internationally. He has held over 200 workshops and taught over 5,500 orthosurgeons all over the country and abroad. And he has been an organizing secretary of Golden Jubilee Icon at Mumbai, which was held at Mumbai at 2005. He is the past president of the Bombay Orthopaedic Society, past chairman of the National Trauma Committee. And ladies and gentlemen, I can continue to go on and on Dr. Ram Prabhu's achievements. But certain other things which I would certainly like to mention is co-authored 4 books on trauma management and has been awarded author of Best Book Award in 2008 and ultrasonography of shoulder in 2012 by the Bombay Orthopaedic Society. Dr. Ram Prabhu loves mountaineering and he has made more than 30 trips to Himalayas and Alps. He loves to travel, he enjoys music, and he loves organizing events and making friends. With these words, I welcome Dr. Ram Prabhu to this gathering. And we, sir, all look forward to be enriched by your experience and your thoughts. And last but not the least, ladies and gentlemen, we also have a very young spine surgeon, Dr. Kiran Prabhu, who is shouldering the responsibility of taking us through the question answer session, or he's going to moderate the debate subsequent to the presentations of Dr. Acharya and thoughts of Dr. Ram Prabhu. Dr. Kiran is a graduate from Bombay, from D.Y. Patil Medical College and Hospital, and he has done his MS in orthopedic surgery from Rural Medical Sciences Institute at Pravra. He has been a fellow of Spine Foundation US from 2016 to 2018. He has been an invited faculty at various national and international symposia. He has been an organizing secretary of Young Surgeons Forum at Mumbai and a chairman-elect of Young Surgeons of Asia Pacific Orthopaedic Association. Currently, he is associated in Mukund Hospital, Guru Nanak Hospital, and Holy Family Hospital, and has special interest in playing tabla, ladies and gentlemen. So he loves music, he loves sports, and he loves friends. So something has rubbed off from Dr. Ram Prabhu to Dr. Kiran Prabhu. With these very words, I welcome you all, and I welcome the faculty, and I request Professor Kiran Acharya to start the deliberations on the utility of FRAX. It's over to you, Dr. Kiran Acharya.
Thank you, Harsh. And I thank OrthoTV, and I welcome my panelists, Ram Prabhu and Kiran Prabhu. And just we wait for the share of the screen.
It'll be a...
Yes. So this program encompasses just osteoporosis in a capsule and a discussion on FRAX. And I'm Kiran Acharya from Manipal Academy of Higher Education. And my co-presenter or person to discuss today is Dr. Ram Prabhu, my good friend, and Kiran Prabhu to manage the discussion part. As busy orthopedic surgeons, we keep seeing these kind of cases, and advances in orthopedics also focus on managing fragility fractures, osteoporotic fractures. Implants have evolved over the decades to give us a better fixation, better biomechanics, with the idea of making the patient ambulant as early as possible. And our aim is to not to see such articles in the lay press when they say why hip fractures in the elderly are often a death sentence. So we always believe in prevention is better than cure. So elderly can fracture their bones even with the replaced parts. And we have the technology to tackle all this. Idea of putting up all these slides is to talk about the prevention. How can we prevent all this? And that's a focus of today's discussion. As orthopedic surgeons, we have a busy practice. We always are busy with fixing fractures. So we also have to reserve few of our time, few of our minutes and efforts to have a prevention of these, especially in the relatives of the patients whom we treat. And we also should be aware of various technologies available: bone void fillers, special implants, HA-coated implants, or special implants for osteoporotic fracture fixation. With this, I will briefly say, as an orthopedic surgeon, we know that osteoporosis is a poor quantity, where a quantity of the bone is less, in contrast to other conditions like rickets and osteomalacia or osteosclerosis, where there is poor quality. And there is a long definition for osteoporosis. Basically, it leads to reduced bone mass. And the factors are many. In today's world, it is the stress is one of the major factors. Lack of exposure to sunshine, lack of proper diet. And then there are a big list of risk factors: rising age, alcohol, smoking, genetic factors, prolonged bed rest, and previous fractures, steroid intake are other factors which are blamed for osteoporosis. What is probably forgotten by most of us is prolonged medication, especially the proton pump inhibitors, and some other medications which are given for a long term. Long term means more than 3 months of medication. They interfere with the calcium metabolism or absorption of nutrients from the diet, which can lead to a bad osteoporosis. And some of the medications also make the patient prone for falls. So to summarize, the problem is really big. 1 in 5 or 1 in 3 male and females who are visiting your OPD above the age of 50 years are prone for getting osteoporosis. That's the numbers if you have to generalize. And Dr. Ram Prabhu will. Sir, your mic.
Thank you very much, Dr. Chaturvedi and Dr. Acharya, for getting me in this great discussion. As Dr. Acharya has said, the beginning, the osteoporosis is really a dreaded disease. Unfortunately, it's a silent one. And that's the reason why we most of the times don't come to know till we actually see a fracture. So in postmenopausal women as well as males above 50, we see these problems of osteoporosis. And it's, as you know, it's an imbalance between the bone resorption and bone formation. So we have an interplay of osteoclasts and osteoblasts, which is extremely important to keep the balance of bone proper. And when there is a improper balance, that results in osteoporosis. And that is where the orthopedic surgeon comes, and that is where we need to really look after these bones. So we have to first of all know the physiology of the problems and the pathology, which is along with this bone resorption and formation. Next.
There's also a concept of peak bone mass, which is attained by every individual between the age of 25 and 30. And that's an active period of any person. If there is any event in his life at that time, maybe a road traffic accident with a fracture or malnutrition, it can lead to a bad osteoporosis later in life. And they have analyzed why this peak bone mass is less in few individuals. It's basically the lack of protein intake, vitamin D, micronutrients. So in the age group of 25 to 30, lack of these things can cause osteoporosis definitely later in life, more so in women. And there are statistical differences between India and the West. The biggest statistical difference is earlier age for fragility fractures in Indian population, unlike the Western population. And if you have to list the clinical features, like Dr. Ram Prabhu said, it's a very silent condition with non-specific symptoms like backache and malaise.
And that's the reason why we know that we have to earlier detect this in order to prevent all the complications which occur over a period of time. So that's why even if it is silent, so we have to see that after the peak bone mass is achieved, maybe at the age of 25 to 30, and then there is a formation of that peak, and then slowly the bone starts deteriorating, when depending on the balance of osteogenesis and osteoresorption. And that's the reason why we have to find out whether any person or a women in particular, whether they are probably going to suffer from osteoporosis in future. And as you know, the morbidity of this, and of course, in some cases, even mortality, is huge. And that's the reason that we have found out that osteoporosis could be one of the greatest killers next to cancer. And there have been umpteen number of papers which tell us the bad effect of osteoporosis over a period of time. And now we know that with changing medicines, with good health of the people, that people are living longer, and we easily see people living till 70 and 80. And that's the reason why we see all these people having these problems, osteoporotic problems. And that is why it's a great responsibility on orthopedic surgeons to not only manage that osteoporosis, but also those kind of fragility fractures have to be seen. So we have to find out those patients or those people, women or men, who are at risk right in the beginning of their career. So even if it's somebody is 30 years old or 35 years old, we have to always keep that in the back of our mind, that we have to prevent not only osteoporosis, but early degeneration of the problems. Next, please. So we have a prevalence, which is mind-boggling, and we have to find out how much is the prevalence. And you will realize that it is almost 25.8% to 62%, which is there, and in postmenopausal osteoporosis. And as you can see this, it's more than 40% from the age of 40 years, more than 62% by the age of 60 years, and you can see it's almost 80% by the age of 65 years. So this is the prevalence of low bone mass that we see. So just to remember easily, it's 40, 60, and 80 over a period of 40 years, 60 years, and 65 years. And this is the burden of osteoporosis that we can see just because there is a low bone mass, which is, of course, many times is silent. We don't even have any signs and symptoms. And that's the reason why we have to see all these postmenopausal women. And sometimes in India, especially, we see the menopause much earlier at the age of 35 and even below the age of 40. And this is the population that we have to aim to find out if there is any possibility of problems in the future. Next, please. So we have one other important aspect along with osteoporosis, which is the bone which is becoming weaker. But at the same time, we have sarcopenia, which is a very important factor where the muscles actually become weak. And this can cause, have a syndrome, which is sarcopenia with osteoporosis, and we call it a Ferality Syndrome. So many times we see people, old people, have a very minor fall, low velocity fall, and these falls may be pertaining to not only bones which are weak, but at the same time muscles which are weak. And we have to look into that muscle weakness also have to be checked. We have to take care of that. And that's why whenever there is a fragility fracture of the bones and muscle, and that's the reason why we call it musculoskeletal system, we have weakness in the bones which we have to look after, and this is what we are going to talk about today. And at the same time, sarcopenia, which is a very, very important aspect, which also have to be looked into. Next, please.
So WHO has defined normal bone density, osteopenia, and osteoporosis as various grades of normal. Apart from that, osteopenia is a medium level of weakness of bones, fragility of bones, and osteoporosis is the most severe, and -1 being the normal. And how to measure these things, we will discuss in a little while. And we all know that the effect of osteoporosis, which is silent, seen as a fragility fracture. Fragility fracture is a fracture due to a minor fall. Distal radius, spine, and neck femur are the three most common sites. Any bone can fracture if it is with osteoporosis.
So when we see any fracture or an X-ray, the first important thing is to investigate after we have got this diagnosis. So we have to have a diagnosis of a fracture, but we have to confirm that it is pertaining to osteoporosis, or we call it a spontaneous fracture. Sometimes we also call it a pathological fracture. So we have to investigate to find out. And we also have to find out whatever the risk factors are. We have a tremendous history that is there, whether the patient has had this kind of fractures in the past, whether this patient, the postmenopausal women, has any parental history of fractures, especially her mother. Then we also have to see in males whether there is any alcohol, whether there is any smoking in the past, or he's been taking those, is he addicted to that? At the same time, we have to find out whether he is also on some kind of drugs which can reduce the bone density. And the particular drug that we look after is steroid. And the steroid-induced osteoporosis is very well known. So these are the risk factors. Along with that, if the patient also has rheumatoid arthritis, that has to be checked. We have to also see whether there is a genetic involvement of any fracture. So there are refractory osteoporosis that seldom we see, which also have to be seen. So these are all the risk factors, along with the age, the BMI, the BMD, that also has to be checked of the patient. So patient with the fragility fractures have one or more of these risk factors which are there. And if we go into the details of the history, we will definitely see few of them. So after finding out the diagnosis, knowing this osteoporosis, we have to monitor the treatment. And that is perhaps the most important aspect. Any doctor, any orthopedic surgeon is going to operate and keep those bones aligned till it unites. But for union in osteoporotic bones is a daunting task. And that's the reason why we have to give some supplementary, which we are going to talk about little, although that is not really a topic that we are going to discuss the treatment, but we will definitely delve into it. Next, please.
So one point we orthopedic surgeons should remember is that to make a diagnosis of osteoporosis, X-ray is not sensitive. By the time X-ray shows osteoporosis, so-called classifications, Singh's index, Munich index, and Klee-Cooper score, 25% of the bone mass is already gone. So it is not an early indicator. So X-ray, there are various signs have been described. I'm not going to elaborate, but patients coming to you with this kind of deformity definitely have a severe osteoporosis. The gold standard for evaluation of bone mineral density is DEXA, dual energy X-ray absorptiometry. And then other one is a bone densitometry by CT scan, quantitative CT, a regular CT scan with the algorithm for calculation of bone density. And then finally, which routinely used for screening is ultrasound, qualitative ultrasound. Problem with all this is these require, first two at least require a visit to a hospital. Most of our 100 million postmenopausal women, 60% of them are in the villages where They don't have access to basic healthcare, leave alone DEXA and QCT. So probably screening tools are better, where the tools can go to the patient than or a person than they coming to the hospital. So DEXA is a gold standard. There is no doubt about it. But access to DEXA, which is measuring the density in the spine and the hip, is limited, and it does involve cost. Quantitative CT, again, it's involves radiation. Ultrasound, even though literature doesn't support the use of ultrasound, if there is no other screening method available, this seems to be a good tool where, in a temple fairs or a village fairs, they can conduct these quantitative ultrasound as a screening method. And we can find out those at risk. And scoring of bone density is by T-score and Z-score. These are all available in the literature.
So Dr. Acharya has just talked about all these investigative factors, but unfortunately in most of these our osteoporotic patients, the majority of them are found in rural areas where the facilities are not there. And then how do you find the patients who have a fracture risk? So we have this tool, which is FRAX tool, which we can find out from the history and the risk factors that I talked about. We have to find out, enumerate that. If we do not have time in those camps, we can actually have a counselor or a health worker who can help us in finding out this history. So we have to finally find out the clinical risk factors which have to be found, which is considered. So in 2008, the WHO unveiled this fracture risk assessment tool, which is called FRAX, to calculate the percentage of 10 years of probability of a patient sustaining fracture. So we not only can find out the real-time probability of a fracture, but we can also find out if there is a possibility of a fracture which can occur in that particular patient over a period of next 10 years. And that is where I talked about the risk factors, the age, the BMD, the BMI, the history of alcohol or smoking, the history of any fractures in the past, the history of parental history of fracture, and rheumatoid arthritis, taking steroids, etc., are extremely important factors which are taken into account in the fracture risk assessment tool. And this is how the questionnaire is. This is the calculation tool, and this is how the FRAX, the form can look, and we can actually fill in those small check-in points, and we can find out the risk in that. So this is a
web-based tool,
yes,
specific for each country. And this need not be done by the orthopedic surgeon or a doctor. This can be done even by a secretary when the patient is waiting for their turn in an orthopedic surgeon's consultation chamber. This can also be done for the relatives of the patient who are visiting as an added incentive. And age has to be entered, sex has to be entered, weight and height for the BMI calculation, previous history of fracture, parents hip fractured, current smoking, glucocorticoids, rheumatoid arthritis, secondary osteoporosis, mostly endocrinal, alcohol 3 or more units per day, and if available, BMD score can be added to this to make it even more robust. But FRAX tool can be used even without BMD with you. So it gives you the risk factor like this.
Yeah, so we can find out the risk factor from this. And at the same time, as Dr. Acharya rightly said, we can not only do the patient's FRAX, but it can at the same time can be extended to the relatives. The relatives can help getting this form done, and we can also find out from the relatives whether he or she is exposed to this kind of risk. And many times we have found out that even the relatives who come for this test are also vulnerable for these fractures in future. Next, please.
So we know the fracture risk in most patients. Even BMD can give a fracture risk, but FRAX gives us without the BMD. And there are some continuous variables in calculation of FRAX tool. One is age, which is 40 to 90 years, and then body mass index. If available, BMD of the hip is taken into consideration. Advantages is it provides an objective and reproducible documentation of the severity and impact of the condition. I would not call it disease because this is done as a screening method. And a documentary evidence of you having initiated an attempt to treat or detect osteoporosis. When you write a FRAX score in the patient's case record, means that you have thought about that condition. And basis for getting a biochemical investigation or a BMD checkup by DEXA or other methods, this forms a basis. So all patients, yes, all patients who visiting you need not undergo BMD testing. This FRAX will show a direction whether they need to get it done or not. Yes, sir, you are right.
The most important with these FRAX that we can follow up the patient over a period of time, maybe 10 years, and we can actually see the deterioration or becoming better over a period of time. So this is an objective information that we get of osteoporosis. At present, we do not really have many other tools at our armamentarium besides BMD, which becomes a little difficult and expensive in the rural setting. So FRAX is an excellent tool. Unfortunately, it is not much used. You will be surprised that the places like Bhutan also have per million, that's what we count. They have almost 300 per million FRAX users. But in India, it is hardly 40 to 50. So it is unfortunately not really well advertised maybe, or whatever reason that we are not using this FRAX. But I think it is a great tool for all of us to use. And this is what is our message today about the FRAX. Next, please.
There are some limitations for FRAX. It is an aid. It's not for a treatment guide. It does not take into consideration duration and dose of corticosteroids. And when BMD is added, it does not take a spine BMD. And it's right now, the India calculation is based on Indians residing in Southeast Asia. The Indian calculation was not done at the moment. But as we keep using this tool, there can be emerging guidelines for India-specific FRAX. And this FRAX can be a just guide for further evaluation of the patient or directing the patient for a BMD checkup.
Yeah, so that's Dr. Acharya rightly said that though it is extremely useful tool, but because of the limitation that he talked about, it should be best reserved as a screening tool. So we can actually do 100, 200, 500 patients in the medical fairs or camps that we have. And at the same time, we can also do the relatives of the patients with the fracture. Those can be assessed too. But please do not use it for the patients with fractures, or because it can have different denotations, and patients who are on the long-term steroids. Again, that can give a very different kind of picture, and patients already on the osteoporosis treatment. So this is what is the limitation, and that's the reason why we have to reserve FRAX. We can't use it for all the 100% patients. Next, please.
Prognostic indicators can be measured with either biochemical markers or by a DEXA scan. Depending on the patient's severity, when to do it can be decided by the treating person.
That's right. So we have in India almost 100 million postmenopausal women who suffer from osteoporosis, and most of them, as you know, I would say more than 60 to 70% of them are in rural areas. And that's why we have to, where there are sometimes no doctors available, no specialists available. And that's the reason why healthcare workers or Anganwadi workers, etc., can be trained to get these questionnaires filled. And this could be a good screening tool in case if there are huge number of patients, they could be referred to a district hospitals, etc., for the further treatment. And that is where actually India requires this kind of tool to find out the postmenopausal problem and how we can treat them. And we, unfortunately, at this moment, they are beyond the reach, and we have to get these FRAX advertised or dissipated to the smaller areas, tier 3 cities and in the villages. Next.
So depending on the risk factors, if the FRAX score says that the risk is very high, that patient definitely gets referred to a DEXA scan, intermediate risk as well. And if osteoporosis is present, high FRAX, the pharmacological treatment. Low risk means it can go for a lifestyle management. Whereas if the FRAX risk is low, a patient is just asked for a regular reviews and advise the lifestyle management, which also includes exercise therapy. And finding individuals with the increasing incidence of osteoporotic fracture is an important challenge in the field of osteoporosis. And reserving the DEXA scan for those at risk is the message. And teamwork is also important for patients who are on refractory osteoporosis diagnosis. Patients who have had a family history of fractures, it's always good to involve a friendly physician or an endocrinologist or a gynecologist for postmenopausal women. And orthopedic surgeon always is in the front line of receiving these patients because they come with a musculoskeletal symptoms or fractures. Emphasis on diet is important. Regular intake of vitamin D and calcium supplementation for those at risk. Considering the treatment by pharmacological means for postmenopausal women or for men for more than 50 years with a hip or a vertebral fracture, T-score at or less than -2.5, low bone mass and a FRAX risk score showing high, they need to go for specialized pharmacological therapies. The broad headlines are a stimulation of a bone formation, parathormone analogs, teriparatide or strontium granulate is another option, suppression of bone resorption by bisphosphonates and calcitonin. And then we have the agents which act at the level of the receptors. These are reserved for very specific cases. So we should know that pharmacological treatment is a mainstay for those at high risk. Then there are some nutrients which are also important. Folate and B12 deficiency can lead to hyperhomocystinemia, which leads to risk of osteoporosis, cardiovascular disorders, and then also cerebrovascular accidents. In this paper, it very clearly mentions the guidelines for treatment, methylcobalamin for remethylation, pyridoxal phosphate for transsulfuration, zinc and magnesium. All this finally leading to decreased osteoclastic activity, increased osteoblastic activity, maintenance of collagen homeostasis, bone matrix synthesis, and prevention of osteoporosis.
So we should remember, as Dr. Acharya said, that it is extremely important to also find out about the homocysteine, because if it is more than 15 micromoles per liter, I think we see that there is a correlation of osteoporosis with hyperhomocysteinemia. And that's the reason why we have to find out the homocysteine. And we have given all these nutrients. The vitamin B12 and folic acid is extremely important to take care of that. Unfortunately, not many of us actually are doing the levels of homocysteine, and that is also not necessary. If we can manage that with giving vitamin B12 and B6 and folic acid, that helps in taking care of hyper homocysteinemia, and that's how we can manage that. And we have to supplement that whenever we are giving calcium and vitamin D. So also the problem with the patient is there is a non-compliance. As you can see, almost 45% of the patients in the first year and 57% at the second year are non-compliant, and they stop the treatment, and that is where the osteoporosis has a great problem, especially in India. And that is how we have to actually regulate that, see those patients for the follow-up, and do this FRAC again and again if need be. Next.
One way of getting the compliance right is to have a follow-up with the database. So, and conduct of a periodic osteoporosis clinic in your clinic. You can designate, like say, second Saturday of every month, we run osteoporosis clinic, and focused group patients can come during that time. And the compliance increases when you have a designated day for osteoporosis patients. In
as I suggested, for that to have the compliance, I think it will be a great idea for some pharma companies like Pulse to have osteoporotic clinics all across India, maybe 50, 100, and they will be dedicated looking after the osteoporosis, and they can also look after the follow-ups, which is extremely important to have this over a period of time. Food for thought for Dr. Chaturvedi.
And there are a few things we have to keep in mind, that after initial 3 to 5 year treatment period of osteoporosis, comprehensive risk assessment needs to be redone, and no pharmacological therapy should be considered indefinite. And appropriate risk assessment and treatment measures for osteoporosis have to be initiated with the help of screening tools and diagnostic tools. And treatment decisions, duration of treatment, and follow-up prognostic indicators are always individualized.
And this is perhaps a very important slide for everybody to remember. These points that he has talked about is extremely important in the treatment management protocol of osteoporosis. And that we should remember that there is nothing like a therapy which should be given indefinitely. That is very important. At the same time, it is customized and individualized treatment in every osteoporotic patient. And we have to, and all those risk factors that I talked about are very important to find out and individualize the treatment. And that is the crux of the treatment protocol. Otherwise, we'll be treating all the osteoporosis with the similar, same thing, which cannot work in all the cases. Next, please.
To keep the bones healthy and to keep the joints active, to keep the bone muscle mass, and to maintain the bone mass, exercise has to be emphasized. And we have recently conducted a study where effectiveness of lifestyle modification intervention program on quality of life, bone health status, physical function capacity, and medication adherence. All these were done as a byproduct of our osteoporosis clinic in Manipal, and it's been published in July 2021. And this exercise therapy, reminders to the patient on medication, were all done with the help of a special app developed by a startup group here in Manipal, and it's been very effective. We also have another paper published on the same experience on a different line, current available evidence on home management of osteoporosis during COVID-19, because most of our patients could not be screened or could not be followed up during the lockdowns. And we were able to be in touch with the patients because of this app.
Dr. Acharya, I see very distinctly all your papers and research you have done with some Dr. Prabhu. Is it a coincidence or you have an affinity for that, Dr. Prabhu?
No, we have everyone. We have, it's like a very secular group here. Jyoti Shetty also we have. He is my physician and Jyoti Shetty is my endocrinologist.
Okay.
And we also involve nursing and physiotherapist. Because we are a university, we involve everyone. And more effective treatment can be done and more publications can also be made so that we share our experience.
That's right. So it's very important that it has to be a team approach, as Dr. Acharya said, and I will also emphasize that it is not only orthopedic surgeon, but you have to involve a physician, sometimes endocrinologist. I would not say in most of the cases endocrinologist, but some cases which are refractory, we have to involve the endocrinologist, and at the same time gynecologist, because more than 50% of the patients are women and more than 75% of the patients are postmenopausal out of those. So we have to involve them, and the importance of physiotherapist, the muscle physiologist, the exercise therapists, etc. are also important, so that the muscle mass is improved and we have a patient who has a good musculoskeletal system, which is important. Yeah. So I think we have left Dr. Tanay, but I think he can put some focus or some spotlight on the spine, whether he
Yes,
has
definitely.
anything to say about spine fractures in particular, what is his protocol, or whether he can actually differ from our modalities,
Dr. Tanay, you will see the patient with the fragility fracture of the spine. And what's your take on further management vis-a-vis a traumatic spine fracture? Tanay, are you there?
Tanay, can you hear us?
Okay.
Yeah, Dr. Tanay, the fragility fractures of the spine or traumatic fractures, I mean, do you have any protocol fixed?
As the fragility fractures, which are very common nowadays because of the age related, as we always do in the spine, I prefer to do a DEXA scan almost for all the patients. We do a close follow-up of them every year, giving them the medical management, either started by us, orthopedic surgeon, or the spine surgeon itself. Of course, sometimes guidance of the medical physicians, as mentioned by both of you, is needed, or endocrinologist, as in if it is not working, if there are some other causes of the osteoporosis. So definitely that has to be maintained and checked. Traumatic spine, related to that, when there's trauma, it is having no neurological deficit, then maybe we check the values. If it is very, very low, then we may have to start the anti-osteoporotic treatment, maybe in the form of injectable to get the bone stock better. And after that,
Okay.
Yeah. Okay.
I think the signal is an issue.
I think, yes, the internet.
Do we have any other questions, sir? Dr. Ram?
I see questions in the sense that, see, we always have been talking about FRAX, especially in India for last 10 years. But in your practice in Manipal, South India, how much is it really followed? I mean, because we see the awareness may not be there, or maybe people, I don't know whether it's a time factor or why. Why is it not used?
Practice-wise, orthopedic surgeons are always busy with so many things happening, and we are always multitasking. So if you have a patient who is coming to you with the aches and pains, and in the category of a postmenopausal or above the age of 50, a patient who is not responding to your usual treatment of non-operative management of backache with radiology, MRI normal or near normal, usual spondylotic changes, always think of, or a patient with a frequent falls, always think of osteoporosis as one of the problems. And in a busy clinic for any orthopedic surgeon, I'm sure there are hands available outside his office.
Yeah,
they can run this FRAX tool. If there is no access for the computer also, it's fine. You can always take a paper print, and then you can enter the data. Someone can enter the data and get a score from the computer.
Yeah,
and it's easily done. It's doable. We have done it. It's doable. Only awareness needs to be spread regarding the use of FRAX.
So when we are talking about 100 million postmenopausal women having this osteoporosis, I think the disease burden or osteoporotic burden on the population at large is extremely wide. We see not only the problems of osteoporosis, but we see also the economical implications of that. So I think it has to be, this problem has to be absolutely dealt with combined efforts of pharma companies, combined efforts of orthopedic surgeons. And this has to be really, of course, we cannot get rid of osteoporosis, but we have to, this is a great problem that we have now and in future. And I think it has to be addressed very, very well and head on. And that is my message to everybody. And we have to find out, because see, it is not the fracture that we are treating. We are treating an individual. And patients who have hip fractures, spine fractures get bedridden, and the whole family gets affected. And there is a huge economical burden on not only them, but it's society in general. So I think this is a very important message from this today's webinar, that osteoporosis should not be neglected. It is a very important aspect of not only orthopedic, but other doctors too. It starts from a general practitioner or physician level. It goes to the orthopedic surgeon where we require the operation. But we must treat that medically. We must investigate it properly. And we have to find out and go to the depth of it to find out how and why this problem needs to be managed.
And in this regard, I think the role of national bodies like Indian Orthopaedic Association in pressurizing the policymakers to make a FRAX as one of the tools for screening.
Yes.
We can do that. We can give a recommendation as a national body.
Yes.
And it can be easily carried out. I think if we prevent fractures, if we prevent pain and agony to these patients and have a healthy nation, I think it's the best deal one can have. And that's all I have to say tonight.
Absolutely. The consensus, the national body has to have a white paper. It needs to be done almost mandatory in every sort of patient that we see the fracture at least once. You have any questions now? We have any questions from the audience? Dr. Tanay?
I don't know about the audience. I would like to ask Dr. Acharya just one question. What is your management protocol for a hip fracture in osteoporosis? Suppose a person who, a lady who is about 70. In short, I mean, just the.
In short, yeah. Fracture management is the best possible biomechanical implant, and then making the patient as early as possible mobile and mobilize the patient's other limbs, and then initiate the osteoporosis management based on immediate available evaluation using a quantitative ultrasound or a DEXA in the next possible opportunity, have a score, and then proceed according to the guidelines. Pharmacological management mainstay would be teriparatide. It's one which can be initiated even in the presence of a fresh fracture. And minimum duration is 6 months to 2 years, depending on the patient's response.
So we have excellent products of calcium, vitamin D by Pulse, and Dr. Chaturvedi told us in the beginning. So how are you going to incorporate their products in your practice for management of osteoporosis, initially and later?
Definitely, supplementation is the one which is always forgotten. Whether you are doing a biological treatment or you are doing a pharmacological high-end treatment, supplementation should not be forgotten. It's like having a main course food and having a dessert. So you need to have supplementation in all patients, and don't forget to tackle, because whenever we discuss osteoporosis, we only discuss more than 50 years or menopause. Don't forget the biggest population in India, which is 25 to 30 year of age, where they are not getting a proper micronutrients and vitamin D. If you catch that group, you have a very healthy later life. So that is another thing which we all have to remember, because minute we say osteoporosis, we always have a fixed idea that it's only women. No, men also. And then younger age group, if they're healthy, they would be osteoporosis free later in life.
So for that, just to emphasize that, I'll just give an example. In the education, we say that people actually start concentrating on the studies in the 10th and 12th, etc., to get good marks. But I think that foundation has to be done at the 5th, 6th, and 7th standard. And similarly, we have to catch these people when they are young. And that is where the training, the treatment, everything has to start that, including the exercises, supplementation, etc. And we have to be made aware. Don't start the treatment when it is already it's late. So similarly, start at the foundation, as Dr. Acharya rightly said, 30 years, maybe just pre-menopausal, etc. We have to make them aware. So patients, when they come to menopause level, they are already treated, they have given the supplement, they have started the exercising, and all those factors will help them to take over this challenge.
I thank Pulse, Chaturvedi and team, and OrthoTV for giving us an opportunity to talk about our thoughts with the experts from all over the country. I'm told there are more than 1,000 viewers right now. And I'm happy that young spine surgeon Tanay also has joined us in this debate. And over to you, Harsh Chaturvedi.
Thank you so much, sir. It was lovely listening to you and the thoughts Dr. Ram Prabhu has shared with us. And certainly we'll, sir, make an endeavor and look towards organizing osteoporosis clinics. We were doing it earlier also, but probably we'll do it with a greater vigor now. One of the things, sir, which often I think about is, should we not have the assessment of 25-hydroxy-D or let's say vitamin D in the FRAX scale? Why? I always thought that this is something which we have been missing out on. And what are your thoughts on that, sir? First, Dr. Kiran Acharya and then Dr. Ram Prabhu.
Yeah, sure.
If you ask me, vitamin D biochemical assay, I would not do routinely because it will cost about 1,200 rupees. In an Indian population, when they did a study in armed forces in Delhi, where they were well fed and they were in all exercises, they were doing all the exercises, they found 42% of them vitamin D deficient. When that is the scenario, when you have a clinical suspicion which is augmented by your FRAX score, best is to give the patient vitamin D supplementation. And that would be more economical than testing the patient. And yearly by the calendar, they would take the vitamin D supplementation. 60,000 units once a week, about 8 to 12 times is good enough for a year, unless the patient has other risk factors. And the periodic screening of these patients is another which will take us a long way.
So I entirely agree with Dr. Acharya, and I'm concurrent with the similar views that I do not do as a routine vitamin D estimation. I'll give you just simple example. I'm a mountaineer. I do lots of exercise. I think I'm having a healthy diet, and I checked my vitamin D once, and to my surprise, it was just 5. And then that's when I realized that it is across vitamin D deficiencies across everywhere. And as even the military people, the armed personnel also have this kind of problems of vitamin D deficiency. I think the simple economical solution will be to give them once a year a course of vitamin D, which is, as Dr. Acharya, I also give the same thing, 60,000 units once a week for 8 to 12 weeks. And very seldom do I really do vitamin D bone assay unless I see that there is very low and there's some kind of refractory osteoporosis. So I will not incorporate that as an investigation in each and every patient. And that is where we orthopedic surgeons little differ from endocrinologists, where they do all investigations right in the beginning in practically most of the osteoporotic patients. And we are slightly more practical in giving the medicines. Of course, there is one way of looking at problems of vitamin D excess, and which I rarely see. I have seen 2-3 cases of vitamin D excess, but unfortunately, those patients have been going from one doctor to other, and every doctor was giving probably injectables, parenteral, and that is where the problems of hypervitaminosis D occurs. So that is one problem. But then when we are giving oral vitamin D 60,000 per week, I don't think that problem occurs. I don't know whether Dr. Acharya has seen many hypervitaminosis D with oral vitamin D.
For the number of patients benefited, number of patients coming back with the vitamin D excess is negligible.
Negligible, absolutely negligible. So I would rather give vitamin D as a therapeutic treatment rather than to do vitamin D assay. That is my personal opinion. But there are some people who can do and who are doing this. Cost is an important factor.
Sir, I would like to thank you, you and Dr. Acharya and Dr. Ram Prabhu for participating in this discussion. And one thing which has I very well understood, because I always thought there is controversy about the using of FRAX, and then there were certain thoughts as I was rummaging through the literature that it need to be used with DEXA and cannot stand on its own. And as you have put it very succinctly, that the multitude of people that we have in our country, and DEXA being out of reach for most of them. So I believe that take-home messages, we must use FRAX, which has been very much underutilized by the fraternity, and it's such a simple scale, and it gives us the probability for the next 10 years what is going to happen. And I think there are no false positives and false negatives, and it has a fairly good predictive validity, in spite of the fact that we are not looking at vitamin D there. But yes, that is what I understand is the take-home message. If there is anything else to be added to that, sir?
The doctors have to get used to this FRAX tool. They have to get just used to this FRAX tool, and they have to be aware of the advantages that it has. The limitations, of course, they know, but the advantage that they have, if it is percolated to the lowermost or the youngest orthopedic surgeons, the younger generation, then it will be helpful. Next,
yes,
yeah.
Dr. Acharya is saying something, sir.
Yeah, if you wait till 2023, you will have a study from Manipal coming out on FRAX. One of my scholars is doing a study on FRAX, 1,560 patients being analyzed, whose data we are going to calculate FRAX standalone and FRAX with BMD. And they are going to tell you what it is. So the analysis is going on. In 2023, we will have a message. FRAX with BMD or FRAX standalone. We will have a message.
Excellent.
From the Indian population.
We look forward. So I also thank Dr. Chaturvedi, and first of all, my friend Dr. Kiran Acharya, who has got this whole thing conceptualized and have got to the audience. Thank you very much, Dr. Tanay Prabhu. Though we missed you, I think your internet problems are there in Goa, where you are there right now. But at the same time, I must thank Pulse and Dr. Chaturvedi, and most important, Dr. Neeraj Bijlani, who has done a wonderful job of OrthoTV. And I believe that there are more than 2 million viewers that they have had in last 2 years. And that's a great achievement, I must say. It's a great achievement. So thank you, Neeraj, for getting us in today and getting us to the audience. Thank you very much.
Thank you.
Ladies and gentlemen, I thank you very much. The faculty also, the OrthoTV also, and I would like to inform you that next Saturday, 8 to 9 p.m., we are going to have a very interesting tete-a-tete with Dr. Shushruth Babulkar participating in it, along with Dr. Nandu Lal. So do join us on the 12th of this month, 8 to 9 p.m., same time, for another very stimulating discussion. And till such time, take care, goodbye.
What is the topic? What is the topic next week?
Sir, we are talking about FRAX and its utility, and in osteoporosis related fractures.
Okay.
We'll share the link, sir. The sooner it is ready. And yes, and as I promised everybody, thank you very much, sir, for a very exciting and very thought-provoking evening.